Good morning everyone. Welcome back to the channel. Today we will continue the session of antiviral agents, and today we are going to discuss antiretroviral drugs. That means the drug used in HIV/AIDS. We will discuss the pharmacology and also a few pharmacotherapeutics of antiretroviral drugs. So let's start the session. HIV stands for human immunodeficiency virus. The antiretroviral drugs act against HIV, which is retrovirus. They are useful in prolonging and improving the quality of life and postponing complications of acquired immunodeficiency syndrome (AIDS) or AIDS-related complex, but do not cure the infection. The clinical efficacy of antiretroviral drugs is monitored primarily by plasma HIV RNA assay and CD4 lymphocyte count carried out at regular intervals. Now let's see what an HIV virus is. Human immunodeficiency virus is a unique type of virus characterized by its single-stranded RNA and retroviral nature. What sets it apart from its ability to perform reverse transcription, a process where it converts its RNA into proviral DNA with the assistance of viral enzyme called reverse transcriptase. This is contrary to the usual flow of genetic information where RNA is transcribed from DNA. The primary target of HIV is the CD4 helper T lymphocyte cell, a crucial component of the immune system. As the infection progresses, other cell types such as macrophages may also become affected. A critical point in the disease progression occurs when the population of CD4 cells significantly decreases, typically falling below 200 cells per microliter of blood. At this stage, the individual experiences loss of cell-mediated immunity, rendering them vulnerable for opportunistic infections. If held untreated, these infections can become severe and lead to the person's death. One key challenge in combating HIV is its integration into the host DNA. This integration makes it exceptionally challenging to completely eliminate the virus from the individual's body with current medical approaches. Over the past 35 years, a number of virus-specific targets have been identified and drugs for these have been developed. We now have drugs which effectively suppress HIV replication and restore cell-mediated immunity for variable periods of time. The two established targets for anti-HIV attacks are HIV reverse transcriptase, which transcripts HIV RNA into proviral DNA, and HIV protease, which cleaves the large virus-directed polyprotein into functional viral proteins. Some newer targets being exploited are fusion of viral envelope with plasma membrane of CD4 cells through which HIV RNA enters the cell, chemokine co-receptor CCR5 on host cell which provide anchorage for the surface proteins of the virus, and HIV integrase, viral enzyme which integrases the proviral DNA into the host DNA. This is the classification of antiretroviral drugs, which include nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, entry inhibitors, CCR5 receptor inhibitors, and integrase inhibitors. We will look into all these drugs in the upcoming video. So now let's discuss the first class of antiretroviral drug, that is nucleoside reverse transcriptase inhibitors. These are class of drugs used in the treatment of HIV. After entering cells affected with HIV, nucleoside reverse transcriptase inhibitors undergoes a process where they are converted into their active triphosphate forms. This conversion is facilitated by cellular kinases, which are enzymes within the cell. The active triphosphate forms of nucleoside reverse transcriptase inhibitors competitively inhibit an enzyme called HIV reverse transcriptase. Reverse transcriptase is a crucial enzyme for the replication of HIV. These nucleoside reverse transcriptase inhibitors in their active forms become part of the growing viral DNA during the process of viral replication. Viral DNA is a key component in the reproduction of the virus within the infected cells. Termination of chain elongation of proviral DNA. As the nucleoside reverse transcriptase inhibitors become integrated into the viral DNA, they disrupt the normal process of chain elongation. In other words, they interfere with the extension of the viral DNA chain. This interference leads to the termination of the proviral DNA chain, preventing the virus from replicating successfully. In summary, we can say nucleoside reverse transcriptase inhibitors are the drugs that once inside HIV infected cells are convertible into active forms that competitively inhibit HIV reverse transcriptase enzyme. By incorporating themselves into the growing viral DNA, they disrupt the elongation of the DNA chain, ultimately preventing the virus from replicating and slowing down the progression of HIV infection. Zidovudine is a prototype drug for nucleoside reverse transcriptase inhibitors. It is a thymidine analog which was first antiretroviral drug approved for the treatment of HIV infection. Zidovudine is effective against HIV-1 and HIV-2. It protects the uninfected cell from HIV but has no effect on HIV infected cells. Zidovudine is orally effective. It is well absorbed from the GI tract, metabolized in liver by glucuronide conjugation and excreted in urine. It crosses placental and blood-brain barrier and is also secreted in milk. Adverse effects of zidovudine include bone marrow suppression, anemia, neutropenia. Nausea, vomiting, abdominal discomfort, headache, and insomnia are commonly seen during the first initial stages of therapy. Long-term therapy may cause hepatotoxicity, myopathy with fatigue, and lactic acidosis. Now let's talk about the drug-drug interactions of the nucleoside reverse transcriptase inhibitor zidovudine. The first interaction is zidovudine with paracetamol. Zidovudine and paracetamol are both drugs that are processed in the body through a method called glucuronide conjugation. This is a way the body transforms this drug to make them easier to eliminate. Now when you take paracetamol along with zidovudine, there's a problem. Paracetamol competes with zidovudine during the process of glucuronide conjugation. It's like they both are trying to use the same pathway for processing the body. Because of this competition, paracetamol ends up interfering with the normal processing of zidovudine. As a result, the amount of zidovudine in the blood increases. This increased concentration of zidovudine in the blood can be harmful and lead to toxicity. In other words, it can make the side effects of zidovudine more severe. Other drug-drug interaction is of azoles and zidovudine. Azoles antifungal agents are drugs that can inhibit enzymes in the liver, particularly those in the hepatic microsomes. Zidovudine is a medication that is metabolized in the liver. However, when you take azole antifungals agent with zidovudine, the azoles inhibit the liver enzymes responsible for breaking down zidovudine. As a result, the normal metabolism of zidovudine is slowed down and leading to an increase in the concentration of zidovudine in the bloodstream. This higher concentration can cause toxicity, meaning it may lead to more severe side effects or adverse reactions. Other drug interaction is of zidovudine and stavudine. They both are antiretroviral medications used in the treatment of HIV. The caution here is that these two drugs should not be combined together. The reason is that they both compete for a process called intracellular phosphorylation, which is a step in their activation within the body cells. Combining them can create a competition for the same cellular processes, potentially leading to problems with their effectiveness or an increase in side effects. Therefore, it is generally advised not to use the two drugs together. Zidovudine is typically employed in combination with other antiretroviral drugs as a part of multi-drug regimen. This combination therapy is known as HAART, HAART, highly active antiretroviral therapy, and is aimed at suppressing the replication of the virus, slowing down the progression of the disease, and improving the immune function of individuals infected with HIV. The drug listed such as didanosine, stavudine, zalcitabine, lamivudine, and Emtricitabine are also NRTIs and are often used in combination with zidovudine to enhance the effectiveness of the treatment. Each of the drugs works by being transported into cells and then activated to their respective triphosphate forms. The inhibition of reverse transcriptase prevents the conversion of viral RNA into DNA, thereby hindering the virus's ability to integrate its genetic material into the host cell's DNA. Additionally, these drugs contribute to the DNA chain termination during the replication process, further impeding the virus' ability to produce. In the context of HIV treatment, combination therapy with multiple antiretroviral drug is essential because it helps to reduce the likelihood of drug resistance and increases the overall effectiveness of the treatment. Zidovudine, in combination with other mentioned drugs, is not only used for the ongoing treatment of HIV infected individuals but also for post exposure prophylaxis (PEP) and to prevent the vertical transmission of HIV from mother to child during childbirth. Post exposure prophylaxis involves the administration of antiretroviral drugs after potential exposure to HIV to prevent the establishment of infection. These drugs, didanosine, stavudine, zalcitabine, lamivudine, emtricitabine, and abacavir, are effective orally. Lamivudine is a commonly used agent in antiretroviral therapy (ART) because of its low toxicity and efficacy. Emtricitabine is one of the least toxic antiretroviral agents. Stavudine and didanosine should not be combined because of increased risk of peripheral neuritis, pancreatitis, and lactic acidosis. Abacavir can cause hypersensitivity reactions. Now, unlike zidovudine, tenofovir is a nucleotide analog of adenosine. It undergoes intracellular phosphorylation and inhibits the viral reverse transcriptase enzyme, resulting in termination of chain elongation in HIV DNA. Flatulence can occur with tenofovir. It should be cautiously used in patients with renal disease. It is used in combination with other antiretroviral agents for the treatment of AIDS. Tenofovir and lamivudine are also effective against hepatitis B virus. Now let's discuss another class of antiretroviral agent, that is NNRTIs, non-nucleoside reverse transcriptase inhibitors. They are a class of antiretroviral drugs that are used in the treatment of HIV infection. Unlike nucleoside reverse transcriptase inhibitors (NRTIs), non-nucleotide reverse transcriptase inhibitors do not act by becoming the part of viral DNA. Instead, they work by directly and non-competitively inhibiting the HIV reverse transcriptase enzyme. Some key points to understand about non-nucleoside reverse transcriptase inhibitors are that they include drugs like nevirapine, delavirdine, and efavirenz, and are highly active against HIV-1, which is the most common type of HIV responsible for the majority of HIV infections worldwide. However, they do not have a significant effect on HIV-2. Mechanism of action of non-nucleoside reverse transcriptase is that it will bind directly to the HIV reverse transcriptase enzyme. This enzyme is crucial for the replication of the virus as it converts viral RNA to DNA, as we discussed in NRTIs. Non-nucleoside reverse transcriptase inhibit this process non-competitively, meaning they do not compete with natural substances for binding to the enzyme. Talking about cross-resistance, unlike nucleoside reverse transcriptase inhibitors, there is no cross-resistance between non-nucleoside reverse transcriptase inhibitors and nucleotide reverse transcriptase inhibitors. Cross-resistance occurs when resistance to one drug in a class leads to reduced effectiveness of other drugs in the same class. Non-nucleotide reverse transcriptase inhibitors and nucleoside reverse transcriptase inhibitors target different steps in the HIV replication process. So, resistance to one does not necessarily mean resistance to the other. Unlike some NRTIs that require intracellular phosphorylation to become active, NNRTIs do not need this step. They are active in their original form once they bind to reverse transcriptase enzyme. Let's see the drugs of non-nucleoside reverse transcriptase inhibitors. Nevirapine. It is a highly lipid soluble drug and is almost completely absorbed from the GI tract. It freely crosses the placental barrier and blood-brain barrier. It is secreted in breast milk. Rashes are the frequent side effect of nevirapine. It can cause hepatotoxicity. The risk is increased if the patient is also on anti-TB drugs like rifampin. It is extensively metabolized in liver and excreted mainly in urine. Efavirenz. Efavirenz has a long duration of action and is administered once daily. It is taken on empty stomach. It mainly causes CNS side effects like headache and dizziness. Rashes also occurs with efavirenz. Another class of antiretroviral drugs used in the treatment of HIV/AIDS are protease inhibitors. The examples include indinavir, nelfinavir, atazanavir, darunavir, fosemprenavir, ritonavir, etc. These drugs play a crucial role in inhibiting the replication of HIV by targeting the HIV protease enzyme. The mechanism of action is very simple and yet important. It works by competitive inhibition. Protease inhibitors competitively inhibit the activity of the HIV protease enzyme. HIV protease is responsible for cleaving large viral polyproteins into smaller functional proteins that are essential for the formation of mature and infectious viral particles. By inhibiting the HIV protease, these drugs prevent the cleavage of viral polyproteins. As a result, the formation of final functional, structural, and enzymatic components of HIV virus is disrupted. This interference leads to the production of immature and non-infectious viral particles. The inhibition of protease prevents the virus from maturing properly, rendering it not non-infectious. This disruption in the viral life cycle helps to control the progression of HIV infection and reduces the viral load in the body. Cross resistance is common among the protease inhibitors, but there is no cross resistance with reverse transcriptase inhibitors. Protease inhibitors are often used in combination with other antiretroviral drugs such as reverse transcriptase inhibitors to create more effective and comprehensive treatment strategy. This approach helps to target different stages of HIV life cycle. Protease inhibitors are extensively metabolized in liver. The liver enzymes play a crucial role in breaking down these drugs. Common side effects of protease inhibitors include nausea, vomiting, and diarrhea. Additionally, long-term use of protease inhibitors have been associated with adverse effects such as skeletal muscle wasting, lipodystrophy, insulin resistance, and development of diabetes. Indinavir, which is a protease inhibitor, causes nephrolithiasis and hyperbilirubinemia. Good hydration can reduce the incidence of nephrolithiasis. Nelfinavir, diarrhea is an important side effect of nelfinavir. Ritonavir. Ritonavir inhibits cytochrome P3A4 and reduces the number of drug interactions. It inhibits both HIV-1 and HIV-2 proteases. Low dose ritonavir is used in combination with other protease inhibitors, which is known as boosted protease inhibitors regimen. Ritonavir inhibits metabolism of co-administered protease inhibitors and increases their bioavailability and half-life. This leads to dose and frequency of administration of co-administered protease inhibitors is reduced. Nelfinavir is not combined with ritonavir as it is metabolized by a different enzyme. Another class of antiretroviral drugs are entry or fusion inhibitors. They include enfuviritide and maraviroc. Enfuviritide prevents fusion of HIV-1 membrane with host cell membrane. It blocks viral entry into the cell. It is administered subcutaneously. Injection site reactions like pain and erythema are the important adverse effects. It is given as an add-on drug in patients who are not responding to ongoing antiretroviral therapy. It does not exhibit cross resistance with reverse transcriptase inhibitors and protease inhibitors. Maraviroc is a CCR5 chemokine receptor antagonist. It blocks binding of CCR5 tropic stains of HIV to host cell. It is given orally. It is generally well tolerated. Adverse effects like cough, myalgia, arthralgia, diarrhea, and hepatotoxicity can cause. The last class of antiretroviral drug are integrase inhibitors. They include raltegravir and dolutegravir. They inhibit integrase enzyme, which prevents integration of viral DNA with host DNA. They are effective against both HIV-1 and HIV-2. Dolutegravir is better tolerated and is administered once daily. Myopathy can occur with raltegravir. Dolutegravir can cause hepatotoxicity. There is risk of neural tube defect in dolutegravir during the use in the first trimester. Hence, it should be avoided during preconception period. Rifampin induces metabolism of dolutegravir. Hence, dose of dolutegravir must be doubled when co-administered with rifampin. Now let's discuss the therapy of HIV. For HIV, antiretroviral therapy is given. The objectives of antiretroviral therapy are: first, to suppress HIV replication and improve immune status of the patient. Second, to prevent the emergence of drug-resistant viruses. Third, to prevent opportunistic infections. Principles of therapy. Antiretroviral therapy regimen is used to achieve the above objectives. In antiretroviral therapy regimen, drugs with different mechanism of action should be used so that they produce synergistic effect. Use of drug combinations also prevents development of resistance. It usually consists of a combination of two nucleoside reverse transcriptase inhibitors with a non-nucleoside reverse transcriptase inhibitors or integrase inhibitor or protease inhibitors. Criteria for anti-HIV treatment. The National AIDS Control Organization (NACO) in 2021 has adopted WHO 2016 guidelines for treatment of HIV infection. As per the guidelines, antiretroviral therapy should be started in all HIV infected patients irrespective of CD4 count or clinical stage. Treatment is lifelong. A combination of antiretroviral drugs is used. The first line ART regimen in adults include two nucleoside reverse transcriptase inhibitors plus one non-nucleoside reverse transcriptase inhibitors or integrase inhibitors. The preferred regimen is the following: Tenofovir plus lamivudine plus efavirenz, or Tenofovir or plus Emtricitabine plus efavirenz. Another first line regimen that can be used is Tenofovir plus lamivudine or Emtricitabine plus dolutegravir. Alternate regimens are also stated. You can have a look on them. Fixed dose combination once daily is preferred for initiation of treatment. Monitoring of therapy. Estimation of HIV viral load is preferred. Second line ART regimen in adults include two nucleoside reverse transcriptase inhibitors plus boosted protease inhibitor that we have discussed earlier. The nucleoside reverse transcriptase inhibitors to be used are the following: zidovudine plus lamivudine is the first line regimen, was tenofovir based. Tenofovir plus lamivudine if the first line regimen was zidovudine based, and boosted protease inhibitors. For pregnant women, ART should be started in all pregnant women with HIV irrespective of CD4 count and WHO clinical stage. A combination of tenofovir 300 mg plus lamivudine 300 mg plus efavirenz 600 mg is recommended in HIV positive pregnant women. The treatment is lifelong. The infants of women on ART should receive nevirapine daily for 6 weeks. Now let's discuss the prophylaxis of HIV infection. It includes pre-exposure prophylaxis (PrEP) and post-exposure prophylaxis (PEP). Pre-exposure prophylaxis involves taking antiretroviral drugs before potential exposure to HIV to prevent infection. The target group for PrEP includes individuals at high risk of HIV infections, such as heterosexual men, women, transgender individuals, and intravenous drug abusers. The recommended drug for PrEP is a fixed dose combination of Tenofovir 300 mg and Emtricitabine 200 mg taken daily. Post-exposure prophylaxis involves the use of antiretroviral drug after a potential exposure to HIV has occurred to prevent the establishment of infection. People who may benefit for PEP are those who have had specific exposure, such as through sexual contact, needle prick injuries, or contact with bodily fluids like blood, breast milk, cerebrospinal fluid, pleural fluid, or pericardial fluid. The initiation of PEP is crucial and should ideally occur within 72 hours of exposure. The timing is essential for its effectiveness. In summary, PrEP is a preventive measure taken before exposure to HIV, whereas PEP is a treatment initiated after a potential exposure to prevent the actual infection. Both the strategies involve the use of antiretroviral drugs and are important components of HIV prevention efforts. Preferred regimen for adults and adolescents are Tenofovir 300 mg, Emtricitabine 200 mg, Lopinavir and Ritonavir 400/100 mg, or Tenofovir 300 mg, Emtricitabine 200 mg plus Atazanavir or Ritonavir 300 to 100 mg. The drug should be administered for 28 days. PEP is not required if exposure to tears, urine, or sweat or source is HIV negative. Antiretroviral therapy in adults with tuberculosis. All tuberculosis patients with HIV should receive antiretroviral therapy. The treatment with anti-TB drugs is started first. This is followed by administration of antiretroviral therapy within 8 weeks of start of treatment with anti-TB drugs. With this, we conclude our session. Thank you for listening. I hope you understood it. And if you liked it, please share it with your friends and spread knowledge. Thank you.